Okay, so this is Professor Thaddeus Pope, and this is a short video which is an introduction to the Fall 2012 course, Health Law, Liability and Quality at the Hamline University School of Law in St. Paul, Minnesota. So first, a quick note about course logistics, and we'll get into this in a little bit more detail in the first several classes, but just to take a minute here. The course will be based and anchored primarily in the course twin site, which you should have registered for. And on the twin site, you'll see, or may have already seen, are all the course materials, right? Every case, statute, article, and regulation that we'll be reading in the course. This will be where the quizzes will be posted and where they'll be submitted. Exam feedback materials will be here, and so this and the current and pending, immediately upcoming assignments will always be on the home page. So in general, this will be the primary tool for the course. And if you ever have any problems, either, of course, you can always call 1-800-WESTLAW, or if that doesn't work, just let me know. Okay, so let's start broad. Why focus a course like this course around an industry as opposed to around a unique doctrinal approach, right? So most courses in law school, tax, torts, contracts, antitrust, are more foundational than this course, which isn't defined by the area of law that it focuses on, but it's defined by the industry to which the law is applied. So why do that? It's admittedly a little odd, right? Health law is a really vast field, and some commentators, there's some law review symposia on this, some academic commentators dispute that health law even is a distinct field, right? Because again, it's just drawing on other areas of the law, administrative law, contract law, antitrust law, constitutional law, and applies them to a healthcare actor. But nevertheless, there are in law firms health law practice groups, right? Health law sections of state bars, even national professional associations on health law. So it has a distinct identity. There's something to it. One reason is probably just that health is special, right? It's more special than lots of other industries that maybe don't have special courses just on them. Health, after all, is a prerequisite to whatever else that we want to do, either as individuals or as a society, right? It's hard to focus on making music, raising a family, rebuilding a city, fighting a war, if you're stuck in bed, sick or injured. And health is special not to us just personally and as citizens, but also to us as lawyers. And just to suggest a few reasons for this and why you might take this course, health spending in the United States consumes nearly $3 trillion, right? 18% of the gross domestic product in 2010. And health expenditures are increasing at a faster rate than the growth of the GDP, right? So, well, health is growing at 6.2% a year, GDP is growing at only 4.1% a year, right? And so that naturally means that health will consume an even greater and greater proportion of the GDP. And given how tightly healthcare is regulated at the state and federal levels, it consumes an even greater percentage of legal practice than the percent of the overall marketplace that is represented by health care. And then finally, health law is not just a big and growing part of legal practice, it's a big and growing part of public and political debate, right? Barely a day goes by where we don't hear about how a public or private insurer is struggling to provide coverage, or about tort reform and malpractice damages caps and public coverage. Health is a very broad area. And in fact, health law covers so much that we can't possibly even touch on it all in this course. So there are four main areas that we won't cover: public health law, law and science, finance and regulation, and bioethics. So let me just spend a minute on what isn't covered in this course. So public health law. Public health law has a population focus rather than an individual focus like health law. Public health is often defined as what we as a society do collectively to assure the conditions for the people, the whole community, the whole society, to be healthy, right? So it uses epidemiology to identify the root causes for disease and injuries, and then tries to restructure our physical and our legal environment to prevent and avoid such injuries and diseases. While medicine, which is going to be our focus in the class, focuses on treating the illnesses and the injuries once they've already been manifested, right? And so some of your big public health agencies in the United States at the federal level are the Food and Drug Administration and the Centers for Disease Control, and you have at the local level, restaurant inspection and other sorts of agencies at even at the county and municipal level, right? We hear a lot about how smoking, obesity, AIDS are some of the big epidemics. And public health law focuses on how to use the power of law to prevent or at least reduce such epidemics while still respecting, to the extent possible, individual liberties. So that's one thing that we're not going to be able to get into in this class. And we have a separate class on public health law. In fact, several. We have public health law, food and drug law, and other courses in that area. So life sciences, right, is another area that we won't be getting into. Right. This area, right, focuses on, again, it's itself a broad area, but things like forensics, agriculture, and food ethics, for like genetically modified foods, for example, and focuses a lot on the intersections between law, health, and environmental regulatory law, intellectual property issues such as patents and trademarks, and issues like that. So that's our area that we're not going to get into. A third, again, these are broad categories that aren't that are fluid, obviously, even between each other. Another is finance and regulation. Here, what we're looking at is often the money, how providers operate as businesses, how they interact with the government, So one big issue in finance is access to the healthcare system, which often means a way to pay for it. And so there's public access issues, public insurance issues, and the big ones are Medicare and Medicaid, and there's lots of other public payers as well. And then, of course, there's the private insurance companies, by far and away most notably the employer-provided healthcare insurance. And so this is one big issue that we're not getting into in this course. This is covered in the Organization and Finance course and in some more specialized electives on access to care. Also, not covering some of the regulatory issues, for example, at the federal level, the charitable tax exemption doctrine, 501c3, fraud and abuse issues under the False Claims Act, Stark Act, Anti-Kickback Act, and also Sherman and Clayton antitrust issues. And we're not looking at state regulation issues such as certificates of need. And then finally, there's a number of transactional issues such as mergers and acquisitions, joint ventures, financing, construction, and contracts for third-party reimbursement that we're not going to be getting into. Not getting into criminal exposure for Medicare and Medicaid fraud or labor and employment issues, whether under the Federal Labor Act or other regulation of employer-employee relationship. And then also not getting into elder law and issues of guardianship, long-term care, income maintenance, healthcare funding, or elder abuse. And then the last area, main area that we're not getting into is bioethics, which focuses on moral issues in health. And these are often moral issues because technology advances, medical technology advances, and those advances require us to rethink our very concepts of what it means to be human, what it means to be a parent, what it means to be alive, and so forth. So, for example, with in vitro fertilization and other reproductive technologies, you can take the egg from one woman and gestate it with another, and then raise the child with a third woman. And who is the mother? Are they all a mother? So it challenges the very concepts that might have been settled for a long time. Other issues push the limits of autonomy and liberty. Right? Should you have the right to hasten your death with lethal drugs if you find your life intolerable? How do we adequately protect patients and research subjects from being exploited or mistreated? And then there's other issues like distributive justice and fairness. How do we allocate scarce resources like human organs? So that's what we will not cover in the class because it won't fit and because those things are covered in other classes. So I just want to spend a few minutes on what we will cover in this class. And this is a picture that's meant to illustrate what we're going to focus on, which is the relationship between the patient and the clinician, right? That's the paradigm focus point, the paradigm interaction. There's two actors. There's a clinician, usually a physician. Sometimes we'll have other clinicians, such as nurses, in our problems. And then there's the patient on the other side. And it's that relationship, those two actors, and the relationship between those two actors, and the law that affects the relationship between those two actors, that's the focus. just drawing that graphic a little way, this is the focus: clinician-patient, patient-clinician, the law that affects the relationship between those two. Again, there are lots of other relationships out there that's covered by other areas of health law, the relationship between the clinician and the government, for example, in how they bill, how they're reimbursed, and so forth, not the focus. There's the relationship between manufacturers of medical devices or drugs, their relationship between the government, not the focus. So the theme, when we're looking at the relationship between the patient and the clinician, the theme here throughout the whole course, from the beginning to the end, from August to December, is on liability as a mechanism to assure quality health care. There's lots of mechanisms out there, both in the way physicians are paid, and there's lots of other oversight. But one key legal mechanism that's used to help assure, incentivize good quality health care is the threat or possibility of liability. And that's the main focus. But just to remind ourselves that we have overlapping and redundant mechanisms in our system to help assure good quality health care, we'll look at least one other mechanism out there, and that's the licensure system, right? So both physicians, nurses, other healthcare providers, as well as the facilities such as hospitals, all need licenses to operate. And so we have both a gatekeeping role and a policing role that's served by the licensure system, and that supplements the liability system to help assure good quality. So what I've done here in this little pie chart is indicate the relative amount of time that will focus on each of these four main areas in the course. So first, and this is where we'll start the course in August, is with the treatment relationship. And you can see that's maybe about a quarter of the course, 20% of the course. When must the clinician treat? When is a treatment relationship formed? When may a treatment relationship be ended? Then we move on to, you see the big green, which is probably by far at least half of the class, the single biggest piece of the whole class, focus on medical malpractice. And I'm going to break that down in a minute. And that's looking at medical malpractice against individual healthcare providers. So the physician, right? The individual physician. And then we move to the blue, which is institutional liability. So first looking at hospitals. When are hospitals liable for negligent medical errors? And then moving on to managed care organizations, and when they are liable. And then finally, coming back, having looked at the whole course has been focused on liability, but at the end to save some time to look at licensing as one additional quality assuring mechanism. So just to break the pie chart down a little bit, just to give the big macro level overview of where the course goes, we start with the treatment relationship. We start with the question of when must the clinician treat the patient who seeks her services. And we start with the common law answer, and then we look at the statutory answers to that question, mainly EMTALA. Then we move on to the question of when is a treatment relationship formed, when is a treatment relationship properly terminated, and when can a treatment relationship be limited in certain ways. Then we move on again to this main big piece of the class, which is mostly tort law for the most part, which I've called malpractice. And that breaks into three separate theories of malpractice, which we'll look at in turn. Right? So we'll look at informed consent, right? The doctor's duty to apprise the patient of the relevant benefits, risks, and alternatives to the intervention at hand. Look at abandonment when the physician terminates a treatment relationship, when the patient still needed and wanted services from the physician. And then at what is often just referred to as malpractice or negligent treatment, when the actual treatment that the physician provides is negligent. And so at one level, these are all three theories of medical malpractice. Confusingly, one of the three theories is itself called often medical malpractice, but we'll handle that when we get to it. And after that really big piece of the class focused on the three big theories of medical malpractice, we turn to institutional liability, and we look at hospitals and 3 or 4 theories under which hospitals can be directly liable for a patient's injury, and then theories under which hospitals can be vicariously liable for the torts of a physician or nurse or one of their employees or agents. Then we turn to managed care organizations, and that the liability of managed care organizations largely parallels that of hospitals, but we'll see there are some very important differences as well, especially because of ERISA preemption. Then, because it is a hot and heavily legislated and litigated issue, we'll look at tort reform, medical malpractice reform, and what the issues are and what some of the key mechanisms are by which reform, both the size of awards and the frequency of awards, is addressed. And then finally, like I said, we'll get to licensing. We'll start with the licensing of individual providers, both the gatekeeping function, meaning you don't get to practice medicine until you have a license, just like you can't practice law until you finish law school and pass the bar and pay your dues. So it's a gatekeeping function there. And then, of course, just as you can get kicked out of the bar if you do certain things, you can get kicked out of a medically licensed profession for certain bad conduct as well. And then, just as individual providers are licensed, so are facilities. And so that's where we'll end.